Welcome, everybody. We'll just give a few minutes for everyone to join, and then we'll start. Good morning, good afternoon, good evening. Welcome, everyone. It's great to see the interest here. So good morning, good afternoon, good evening to everyone. We welcome you all, particularly those of you joining from far away or late or early times. My name is Supriya Bezbarwa, and I lead for EPI-WIN. Those of you who have been part of the EPI-WIN family will know this whole routine very well. Thank you for joining this webinar on Sudan disease outbreak, what we know. For those of you who are new to EPI-WIN, it stands for the WHO Information Network for Epidemics, for the Science and Knowledge Translation in Health Emergencies. Our goal is to translate science to accessible, understandable, and relevant ways for evidence-informed actions and decisions in health emergency preparedness and response. Recently, as we know, Sudan virus disease has been in the news, and maybe you've been wondering about it. So today we have a great panel to share with you what we know about it. Dr. Maria Van Kerkhove, Director for Epidemic and Pandemic Threat Management, was to provide the opening remarks. Unfortunately, up to now, she has been held up because we also simultaneously have our executive board meetings going on today. If she does not get here, I will read out her opening remarks, and I hope she'll be able to join us later. But we then have our expert on viral hemorrhagic fevers at WHO headquarters, Anais Lejean, who will tell you about the Sudan virus disease outbreak and Ebola viruses and give you the background for it. Dr. Patrick Ramadan, Otim Patrick Ramadan, who's the Health Emergency Officer at the WHO Regional Office for Africa, will then talk more about it and tell us about the readiness and response, especially at the regional level. And of course, as always, we look forward to your questions, comments. So I'll go to the housekeeping now. As you know, this webinar is being live streamed in the EPI-WIN YouTube channel. The webinar is being recorded, and afterwards, the recording will be available from our website. We'll share the address with you in the chat right now. We love to hear from you. So we invite you to post your name, location, organization in the chat box. We would love to hear where you are joining from. And please add any questions you have in the Q&A box, not in the chat, so that we can keep track of them more easily. But any comments you have, please add your comments in the chat box, but please keep your posts positive and constructive and relevant to this topic. We are here to learn from each other, and let's keep that going. But any rude or obstructive posts will be blocked. But we would love to hear your constructive comments, your views, and any others that help move us forward. So Now, Maria is not here yet, so without any further ado, I will read the welcome remarks on her behalf. So this is on behalf of Dr. Maria van Kerkhove. Welcome to this new edition of EPI-WIN. Today you will be hearing about Ebola diseases with a focus on Sudan virus disease. Ebola virus diseases have been identified in 1976 in two simultaneous outbreaks. One, Sudan virus disease in Nazara in what is now South Sudan, and the other, an Ebola virus disease outbreak in Yambuku in what is now the Democratic Republic of the Congo. The latter occurred in a village near the Ebola River from which the disease takes its name. Since then, recurring outbreaks have been reported in Central and West Africa. A number of progresses have been made to date to better characterize the disease and its pathogens, to improve early detection and care to patients. For Ebola virus disease, we know have close to patient diagnostic tests, approved disease-specific vaccines, and therapeutics. Yet, much more is needed to be prepared and timely respond and mitigate the impact of such outbreaks. Regional efforts are on their way to foster coordination and sustain abilities to anticipate, early detect, and timely respond and mitigate impacts of such outbreaks. WHO works with at-risk countries and partners to prepare, early detect, and control Ebola disease outbreaks, strengthening critical components such as surveillance, lab diagnostics, clinical management, infection prevention, prevent and control, research and development, and risk communication and community engagement. We will now hear further from our experts, but for now, welcome again to this EPI-WIN. I will soon hand the floor to our expert now, Dr. Anais. That was the message from Dr. Maria van Kerkhove. But before we do that, we'd like to hear from you. As usual, those who know from EPI-WIN, we have a Slido for you. Uh, so please share what are the first words that come to your mind when Sudan virus disease outbreak is mentioned. Very quickly, join us at slido.com, hashtag 1108334. Slido.com, hashtag 1108334. Dangerous, fear, emergency, pandemic, fatal, confusing name. Another Ebola pandemic in the making. Mental health, PPE. No vaccine, dangerous, nosocomial transmission. Excellent. There seems to be a lot of fear, deaths, pandemic, certainly a lot of concern there. I will keep this open. Certainly, we'd love to continue to hear from you. I will though now hand it over back to I'll hand the floor to my colleague Anais to start the presentation on Ebola. Over to you, Anais. The floor is yours.
Hi, everyone. Sorry, I had trouble to unmute. I hope you can see my screen in full presentation mode. Can you just confirm? Someone?
Yes, we can see your screen, Anais.
Perfect. So thank you so much for giving me the opportunity My name is Anaïs Legrand. I'm the team lead by interim for viral hemorrhagic fevers. And today I'm going to give you a brief overview. We only have 15 minutes, so I will try to keep on time, of Ebola disease. And I would like to thank everyone who put that words, because for us it's very useful to understand what are the current perception of those diseases. And I've read a lot of words, and I hope we will get some clarification. And of course, we will be available for any further question. So let's start with Ebola disease. And I saw that some of you knew that. Ebola disease, it's kind of a scary name, but we will go through it to see how we can control it. Is a illness that is caused by different species of viruses that belong to the Ortho-Ebola virus genus. I'm absolutely not to give you a talk on virus taxonomy and disease naming because it's outside of my scope. I just want to make it very clear. What we know to date is that 6 species of Ortho-Ebola viruses, so 6 different viruses that group into a genus, have been identified to date, with 4 of them, and these are the ones that are highlighted in the table in blue, have been associated with disease in human, and 3 of them have been associated with large outbreak. So namely the Bundibugyo virus that is causing Bundibugyo virus disease, Ebola virus, that is probably the one you know best, that is causing Ebola virus disease, and Sudan virus causing Sudan virus disease. What's important to remember here, they all belong to the same genus. They have a lot of similarities, and we will go through them, but they also have some slight differences. And this is also what I will try to bring to that table today to clarify, because I know it's very confusing and we get a lot of comments and requests there. So first, as was mentioned, the disease was first identified in 1976. I'm not going to go back there. And to date, 42 outbreaks of Ebola disease, so including all the virus species, have been reported, with the most commonly known being Ebola virus disease, with over 23,000 cases reported since 2076, cases that were mostly driven by the very large outbreaks that occurred primarily in Guinea, Sierra Leone, and Liberia from 2014 to 2016, and then by the large outbreak that was recorded in Eastern DRC in 2018-2020. Today, we are going to talk of all these diseases, but with a focus on Sudan virus disease. There have been 8 outbreaks, excluding the current one that is ongoing in Uganda, and my colleague Patrick will touch base on that, with slightly less than 1,000 confirmed cases reported to date. Of course, you will get access to the slides, so you will be able to read at your own convenience. The main message here is really to try and focus on those 2 viruses that have caused the largest outbreaks, and see what are the difference before we move to the similarities and what we can do about them. So the number of outbreaks is quite different from one disease to another. And again, that's why maybe you know very well about Ebola virus disease. 31 outbreaks have been reported in 11 countries, and 5 of them were due to imported case, meaning that one patient was traveling to another country and got sick in another. For Sudan virus, we have less frequent outbreak because we had 8 prior to the one occurring in Uganda in 2 countries, and those countries are Uganda and South Sudan. When we look at the case fatality ratio, so the number of people who died out of total number of confirmed and probable case, we see a slight difference, although again, we had less outbreak for Sudan virus disease. But the pooled estimate is around 65% for Ebola virus disease, while it's a little bit slower for Sudan virus disease. But as some people of you mentioned, yes, there is a high lethality associated with those viruses, and that's why we need to scale up outbreak response to make sure that affected patients can improve their chance of survival, and we will see that later. In terms of transmission route, so how is it introduced to the human population? It follows a similar pattern. So it always starts, and we will see that in the next slide, generally from a spillover from the wildlife that is then introduced to the human population. For Ebola virus, we've documented flare-up events linked to viral persistence in people who have recovered from the disease. It's a rare event, but this has happened in the past. This has not been documented for Sudan virus disease. But the most important point where we have differences across these two diseases is really about countermeasures that are available. For Ebola virus disease, and again, we had quite a number of cases and quite a number of outbreaks, so countermeasures have been developed over the year. And for that, starting with diagnostics, how we can diagnose acute case, so when people are sick, to make sure this is Ebola virus disease, we have a range of diagnostic tests, ranging from the classic open PCR platform that you have in most labs, to a semi-automated near-patient PCR test that is very useful in terms of patient management, but also some antigen RDTs that we can use on individuals who unfortunately died. For Sudan virus, we only have the open PCR platform. There was this question about the vaccine. We do have 2 approved vaccines for Ebola virus that will work on the Ebola virus, but currently we do not have approved vaccines that will work for the Sudan virus. Though we have candidate vaccine, and you probably have read in the news that a clinical trial started in Uganda this week. Similarly for therapeutics, yes, we do have some for Ebola virus disease, 2 monoclonal antibodies, but currently we only have candidate therapeutics. That means that products that have been developed, but we need to put them into clinical trial to understand safety and efficacy of those. So that's the major difference. Now we will switch to the similarities and most importantly, what we can do about it. So starting with the transmission of all the species of ortho-Ebola virus, and again, sorry for the name, we are not responsible for it. It's a bit ugly, but you get the feeling. So first, for those virus, we think it's not, it has not been fully documented, but we think that the animal reservoir is fruit bats, where the virus can be maintained over time. From the fruit bats, it generally goes, it can be transmitted to other animals that live in the rainforest. It can go from, the most well-known are the non-human primate, like gorillas, chimpanzee, and other, but it can also be transmitted to antelope. In some instances, we've seen epidemics, so epizootics, in animals. So you will ask me, how does it come into the human population? Well, the most commonly known route of transmission is generally through handling infected, dead or sick animals that have been found in the forest, sometimes for hunting reasons and sometimes because of some work that people do in the forest. We think that direct contact with bats can also result in transmission, but this is probably a rare event and has not been fully documented. Once the virus is introduced into a human, we generally see a sustained human-to-human transmission through direct contact with blood, body fluids, organs of people who are infected with the virus, and also contact with a contaminated surface of equipment that have been spilled with body fluids of those patients. We also know, and this has been documented both for Ebola virus and Sudan virus, that the virus may persist for some time in some people, mostly in semen, and that in some instances have led to flare-up events linked to exposure to infected semen. We also know for Ebola virus disease that the virus may persist in the brain of a limited number of people that can create a relapse in a person who already recovered. With this information, it's very important for all of you to understand that not everyone is at the same risk. It's not a disease that is airborne or can be transmitted easily. The people that are at risk are obviously the ones that are in close contact with a sick individual, like family members when they provide care to their patients, It can be healthcare worker, be it formal or informal, along with traditional healers. And of course, when a person dies, the transmission can also happen when funeral rites involve touching of the body. So this is where we will control our effort to ensure that those at-risk people can adequately protect themselves. How can we identify Ebola disease? So it's not an easy thing, but the first thing is first the incubation period. That is the time between when the virus infects you and the time you will develop symptoms of the infection is between 2 to 21 days. And a very important point to remember is that when a person is infected, the person cannot transmit the disease until the person develops the symptoms. The first symptoms that we generally see, and it's common across all the Ebola disease, will be non-specific symptoms such as sudden onset of fever, history of fever, fatigue, malaise, muscle pain, and that is then followed by what we call wet symptoms, so mostly vomiting and diarrhea, with other, of course, clinical parameters that will deteriorate. In some patients, and it's important to insist on that point, in some patients, we can see some bleeding. It will be, for instance, bleeding from the gums, having red eye, but the bleeding, like what maybe we have in our imaginary, like people bleeding for everywhere, it's not something that we see often. It really happens most of the time late in the disease stage. And generally the bleeding are around also the point of injection and these kind of things. But just to call on everyone that we need to recognize those patients before they go to that stage, and not all patients will develop bleeding. So as I mentioned, the symptoms are not specific, which makes the diagnosis very difficult on a clinical basis. And it can be very similar to many other infectious diseases that circulate in most at-risk countries. So that's why on top of the clinical presentation, there is a lot of work that needs to be done to collect the patient history, looking for contact with dead or sick animal, especially at the beginning of an outbreak, or contact with suspected, probable, or confirmed case. The definitive diagnosis can only be done into a lab, and the commonly recommended technique for confirmation would be to use the RT-PCR. I'm not going to get there. If you're interested, there will be next week a webinar from public health laboratory team that will present the new guidance on diagnostic testing for Ebola and Marburg diseases, and we will put the information in the chat. Moving on to, once we've said that, now we know how to recognize the disease, how important we need to have the lab. What can we do when an outbreak is confirmed? So as for any other infectious disease outbreak, we need community engagement. And it's not just words that you say like that. Many of you put in the slide that Ebola is scary. Yes, this is a scary disease. This is a disease that is transmitted when you want to provide care to your loved ones that have symptoms. So Ebola will transmit if the protective behaviors are not implemented among family members, among social networks of people who care for each other. And yes, it's scary. It has a high fatality rate. So you can imagine when there is no ability to isolate early the patient, a lot of family members will be all impacted. So this is why we need to engage with communities and promote behaviors that will help them protecting themselves and stopping the transmission. And for that, we will insist on a few points, which is mostly to reduce the risk of human-to-human transmission. First, by, of course, avoiding close contact with patients when there are symptoms and their body fluids. I know this is not an easy thing to do. I know that most people, if their wife or husband or grandmother or children start vomiting, most of them will want to touch and help them. This is something we have to help communities to stop. And how they can do that? By referring early, as soon as the patient experiences symptoms, as soon as there is a fever, for instance, in an outbreak setting, to go early to a treatment center to receive early care, but also to avoid the transmission at home. In health facilities, extra infection prevention and control measure will need to be implemented, and we will work with health facilities to scale up this capacity to protect healthcare workers, but also to protect co-patients. And finally, as I mentioned previously, we have to work with community to find a balance around how we bury our loved one, balancing the safety, that is, avoid any touching of the body, no washing, nothing, but finding a way to find replacement rights so that communities can still adequately mourn people who died of Ebola disease. One important point, because we said it's little, it's scary, we don't have treatments, but we still have things that can help improve the chance of survival. And starting with early intensive care support, and you'll see our guidance if you're interested, to help the patient as early as possible and to treat all the symptoms this patient will have. For Ebola virus disease, we also have 2 monoclonal antibodies that, in addition to the supportive care, can improve survival rates. Here, and I will absolutely not go into a lot of detail, but when an outbreak is confirmed, there are a number of interventions that are critical. I went through some of them. I want to insist as well of the importance of contact tracing and following, which is basically you will identify all the contact of a person who has been sick and follow this person for 21 days. If this person is experiencing fever, you will refer this person to the treatment center so that she can get tested as early as possible to receive the best level of care possible. This will improve chance of survival again, and this will stop the transmission in community. Those interventions are similar for all Ebola disease, with the difference that for Ebola virus, we, on top of that, have ring vaccination that we can use, and also specific therapeutics. For the other, as I mentioned, we have candidate products that can be used in clinical trial. I mentioned this already, so I will not go through it because I think we don't have time. But here you will find all the information related to Ebola virus disease of the Ebola virus species, therapeutics, and some information on how the International Coordinating Group on Vaccine Provision Global Stockpile can be accessed in case there is a confirmed EVD outbreak, or how preventive vaccination of healthcare and frontline workers can be made possible in at-risk countries through WHO and Gavi. As I mentioned, for the other Ebola disease, there are a number of products that are currently being developed and evaluated, and you'll find all the information there. Similarly, for the vaccine, I'm pretty sure the slide will be disseminated, so you will have access to all of that, and you can read in your own time. I will stop here. You will find also here all the published resources that WHO has, and of course, new are published as needs arise, and feel free to send any suggestion on what's needed on your side. And in case you have further questions or suggestions, please feel free to reach out to me, and I will work with my teams in Geneva, but also at other levels to help you out. Thank you so much.
Thank you very much, Anais, for that excellent overview and in spelling out very clearly the commonalities and the differences between Ebola virus disease and Sudan virus disease. To be honest, even I was confused, so I found it very interesting indeed. And I can tell that many of the participants did as well. There are quite a few questions in the Q&A box, which we will respond to in the Q&A session. In the meantime, also, of course, if possible, I request my colleagues to also answer that. But now we go on. You've heard the overview from Anais. I request Dr. Otim Patrick Ramadan to tell us what is being done for readiness and response, especially at the regional level. So over to you. The floor is yours, Patrick.
Thank you very much, Supriya, and thanks to all the colleagues that have joined on this EPI-WIN webinar. So good to interact with you. I will provide a quick update on readiness and response and give a few highlights on the response that is going on currently within our region. I just wanted to emphasize, I think, one critical point that Anais made and which I have seen coming up in the question, that while we have the Ebola disease, which is a constellation of all those ortho-Ebola viruses that was mentioned, and the three of them that have been associated with large outbreaks, it's very important always to differentiate that the outbreak is due to which disease, because it has implication on whether we have countermeasures available or not, as has been clearly shown. So when we are talking about Ebola virus disease, the one we refer to as EVD, we know that for now we have 2 vaccines that are approved. We have countermeasures such as rapid diagnostic tests and a number of tests and therapeutics available. But when we talk about the Sudan virus, we do not have those. So if we lump all of them together and say we have an outbreak of this, and one moment we are saying we don't have vaccine, and the other moment we say we have vaccine for this, it's clear, it's important to make that delineation, which virus is causing the outbreak and whether we have the tools for it or not. And it's unfortunate that the naming of these viruses happened way back when they were discovered in the 1976s. So sometimes we have names that seem to be stigmatizing. I do come from South Sudan, so I understand what colleagues are raising in the chat, and I just wanted to make that clarification. Now, moving on to provide a quick update. I wanted to start by setting a scene that within our region, we are one among the WHO regions. The African region is one that gets the highest number of emergencies every year. We basically get 2 to 3 new emergencies every week. And in the last 22 years, we've been having an average of 102 public health emergencies recorded. We are really dealing with a triad of infectious disease outbreak, and then we have, which have been very common, we have climate-related natural disasters, and then of course we have conflict-related crisis like we're now having in the eastern part of the DRC. So as of just this last week, we have 89 events that we are monitoring within our region, including 57 disease outbreaks, 32 humanitarian events, and out of these, around 15 of them are significant public health emergencies. In WHO, we call them graded public health emergencies, which means they require a substantial operational response from WHO. And some of them I've listed here, including these 2 that we are talking about. So we have the Sudan virus disease, and then of course we also have the Marburg virus disease in Tanzania. But we'll see that we have gradually been seeing an increasing trend of emergencies each year, and the zoonotic diseases, one of which are is the Ebola diseases that we are talking about, constitute a major proportion of the disease outbreaks that we deal with within our region. So one of the advantages we have had with all these multiple emergencies is that gradually we have been building capacity, and countries, every time we have an outbreak of these highly infectious and transmissible diseases, we do rounds of readiness assessments. So it started way back, even in 2014, when we had the outbreak in West Africa, and we have standard tools that have improved, and gradually now we have them electronic online, that whenever we have an outbreak, we share with the countries, and they do a self-assessment of their overall readiness capacity across the pillars of a filovirus outbreak response. So you will see this one that we used when we had the Mpox outbreak. We have used it when we have the Marburg outbreak in Rwanda last year. And then we have been gradually improving and building on that. When we had the largest, one of the longest outbreak, the recent one in DRC 2018-2020, we had a number of interventions across the countries in the sub-region to try to improve on their readiness. So as we look now this year, for instance, for the current outbreaks that we are dealing with, we have done categorization of countries, looking at their level of risk based on a number of factors. Others, it could be the proximity, the closed borders, high movement across the border. Others, it's terms of the cultural connections, the linkage, the ties, the economic ties, the movements, and we have 3 categories. So the priority 1 countries in terms of those that already have outbreaks, because the outbreaks are not engulfing the entire country. Most of them are delineated in specific districts. So when you have an outbreak in one district, the other districts need to also conduct readiness measures so that they can be able to contain quickly. So you have Tanzania, Burundi, DRC, Uganda, Rwanda, and Kenya as our priority 1. And then also others in that category include South Sudan, Mozambique, Malawi, and Zambia because of the proximity and some of the linkages by road and high traffic that I have mentioned. And then we have the priority 2, which includes Ethiopia, South Africa, Angola, Namibia, and Botswana, and then the rest of the countries. And we usually support these countries to do specific readiness activities so that they are able to respond quite quickly. So for now, we have done all these readiness assessments, which have been building on even from the outbreak we had of MVD last year. Most of the countries have developed their contingency plans. The contingency plans are developed based on the gaps that have been identified in the readiness assessments. And then most of them now, they have their EOCs and IMS structures in place. There are training sessions for the field rapid response teams. We have heightened surveillance at the community level and in public facilities, dissemination of the case definitions. The clinical management guidelines are being updated and finalized, enhanced IPC in the health facilities, dissemination of the key messages, because as Anais mentioned, creating awareness of how how the disease is transmitted and how people can protect themselves is very, very important. And of course, screening of travelers and at POEs, and then cross-border collaboration. As I'm talking, there are ongoing preparations for cross-border meetings between Tanzania, Uganda, Kenya, Rwanda, and Burundi, just to share information and also enable them to coordinate their readiness and response measures and identify joint areas of risks that can be mitigated. So as we start now, a number of the priority countries have updated their readiness status, and you can see in terms of the levels of readiness for the countries, one thing that is very clear, that if a country has had an outbreak recently, you will see that they have a much better level of readiness because they have been through this and they have put up some capacity. But some countries like Malawi, like South Sudan, for instance, which have not had an outbreak in the very recent past, and then they do have gaps. So overall, we see a readiness of 59%, and you will see across the different pillars ranging from coordination to safe and dignified burials, each of the areas where countries have capacities at green or areas where they have gap. And it is this kind of assessment then that we use to offer targeted support to countries to plug in the gaps so that you have some of the reds moving into orange and then to green. So I'll just give a quick comment in terms of, there was an outbreak of Marburg virus disease in Tanzania, and which was declared on the 20th of January. And so far we've had 10 cases. 2 of them are confirmed. 8 were probable, which means that they died before samples could be collected and tested, but they have been epidemiologically linked to the 2 confirmed cases. But so far, we've not had any new case over the last 7 days, and we believe that some of the response actions that have been implemented have been effective. Of all the contacts that were listed for follow-up, only 21 are currently being followed up. The rest have finished their 21 days period for follow-up. And this 21, they will be finishing sometime next week. So once we have all the contacts discharged, then we can just continue in the period of enhanced surveillance as we count down to 0 plus 42 days, which means having no case for 42 days when the end of the outbreak will be declared. There has been a very good response led by the government, coordination mechanisms activated from the national up to Kagera, where the outbreak has been happening, even the Biharamulo District Council, and then enhanced investigation, both prospective to identify the cases and contacts, but also retrospective investigation to try and identify where the index case could have been exposed. And WHO and other partners have been working to strengthen case management and also to ensure that we have sufficient supplies. And being that we also do not have an approved vaccine for Marburg virus, there has also been a work ongoing now, awaiting regulatory approval for a clinical trial of some of the available vaccines for Marburg as well. Now, moving on to the subject of the day, which is the Sudan virus disease. Also, you know that the outbreak was declared on the 30th of January, and immediately the government activated a very swift response. This is the 8th Ebola outbreak in the country, so the country has sufficient experience and capacity to deal with this kind of outbreaks. And the index case has been identified as a 32-year healthcare worker. And as you try to see from this timeline, his symptom onset was from around 19th, and he was sick for around 10 days, and he did visit a number of health facilities. As my colleague had presented, the initial signs of all the Ebola diseases is usually non-specific. So in the tropics, like ours, somebody presenting with fever, headache, joint pain, weakness, vomiting, diarrhea can be a number of diseases. So there were a number. He was treated for malaria and typhoid at some point, but he was not improving until when now the condition was around 29th when suspicion was that when he started having some of the hemorrhagic manifestations, and then he was tested towards the end when he was already dying, and it was positive. So far we have 7 cases, those 6 addition to the index case, and really from 2 clusters. There is the close contacts of the index case, and then there are the cluster of healthcare workers that did attend to him. And then there's been intensive investigation, contact tracing. Over 290 contacts have been listed. And then the follow-up is being done, testing being done for any of the alerts that are being raised, people that meet the case definition. And similarly, a very robust response by the Ministry of Health in Uganda, the National Task Force with the EOC, and also subsequent responses in Mbale, which is the other district where the index case did visit. We also have a very strong team in Uganda working with the Ministry of Health. Actually, our Deputy Director General, who's also the Executive Director of the Emergencies Program, Dr. Mike Ryan, has been on ground. And so we've been putting all our best foot forward to support the government in this response. Strengthened alert management based on experiences from the past, just to ensure that we have quicker turnaround time for results. The government has actually deployed a mobile laboratory to Mbale instead of bringing the samples to Kampala. So there are 3 labs in Kampala that can test, but now also we have an additional 4th lab in Mbale, which is the mobile lab, so for quicker turnaround time. And then one of the firsts that you will ever see, that within 3 days of the infectious disease outbreak, we have a clinical trial that has rolled off. And this is really as a result of the continuous improvement and also the readiness. So when we had the outbreak in 2022 of the Sudan virus, there were preparatory actions that were done, protocols developed, submitted for ethical review and approval by also the Uganda National Council of Science and Technology. So this time we just kick-started the processes that have been there, and then the vaccine trial is now on the way. Also the clinical trial of a therapeutic monoclonal antibody MBP-134 will also start in the next 2 days once all the ethical approvals are obtained. Ring IPC around the affected health facilities being implemented. And also there's extensive risk communication and community engagement, including deployment of anthropologists who have really proved very helpful already in bringing even the traditional healer that was visited in Mbale. they were able to identify him and bring him through engagement with the community. So he's now being followed. And the government has also put in place institutional quarantine for high-risk contacts. That means that all the high-risk contacts that are identified are moved to a designated facility where they are being followed. Now you will see that all these secondary cases that we have got, these are contacts that were already identified, listed, and were in quarantine. It's a very important measure to implement because then it reduces the effective contact rate, and therefore the interaction between these people when they are symptomatic and other people is curtailed, and therefore you contribute to interrupting the transmission much faster. Of course, one of the challenges for both outbreaks is that we still do not know the source. But for this particular outbreak in Uganda, the sequencing of the virus has been done, and it's clear that it is not linked to the recent outbreak of 2022, but the virus has similarity to the one, there was a Sudan virus disease outbreak in Luero in 2012, which means that it most likely also could be an independent zoonotic spillover from that same ecological zone in Luero, and that's what has led to this outbreak. Of course, there are some things to consider for this particular outbreak where we are taking it very serious and responding aggressively in terms of the multiple exposure. The healthcare worker visited several health facilities. He also used some public means of transport. We have increased mobility between Kampala and the neighboring countries. We have concurrent emergencies, particularly the outbreak of Mpox, and then also some of the traditional and cultural beliefs. So those are issues, and some of the misconceptions, misinformation in the social media, those are some of the issues that we are trying to aggressively deal with. I've talked about most of these issues, so I will not re-emphasize this in terms of what is being done. As Anais had shown, so we have all the comprehensive pillars of the response, from coordination, public health measures, surveillance, laboratory, research, operation support and logistics, to risk communication and community engagement. I'll just add that, sorry, all the cases that are currently being managed have been put on remdesivir on compassionate use basis, but then when we have the ethical approval, then the second agent, that is the monoclonal antibody, will then be added. So some quick lessons learned. First of all is the investments during previous outbreaks and during previous bouts of readiness. What we always do whenever there's an outbreak in one country, all the neighboring countries, they have to assess their capacity. Where there are gaps, we have to address those gaps. So this has progressively built national capacities for testing, for coordination, also for case management, as well as for field epidemiology. And you see that within 1 week, you have done a thorough listing of contacts, and you have all your secondary cases coming from your contact list. That is one of very good indices of a very effective field epidemiology at work. You have even the genome sequencing already shared within 1 week. This is real, almost real time, collaboration between epidemiology, laboratory, to inform what our understanding of the situation. Of course, integrating research in preparedness and response. So all the preparatory work, identifying PIs, having the protocols reviewed and pre-approved, and all these things has enabled us, because the outbreak can't be stopped without a vaccine. But the vaccine is an added adjunct that helps us to, reduce the chances of a larger outbreak. So having a vaccine trial now, which is the first one for the Sudan virus, means that we have a possibility of an added tool, just like we have for the Ebola's, EVD, that we can also for SVD in the future have a vaccine that we can deploy in the ring strategy. But also having a comprehensive response, which is rapid, deploying all the RRTs, ensuring we have treatment centers quickly activated so that the people can get the early care that Anais was talking about, because early care is critical to improving the clinical outcome. So initiation of care and then the comprehensive follow-up of the contacts, setting up a quarantine site where you move the high-risk contacts, and then so that they don't, pose additional risk of transmission at the household level. If you keep a high-risk contact in the house and the person develops symptoms in the night, all the family members will definitely care for the person. They will touch the person. So the chance of transmission is very high. So what are the recommendations? I think one of the key issues is the resources. Ebola response in general is a very resource intensive exercise. If you have to do IPC, the ring IPC, you need to identify all the health facilities around where a case has been confirmed. You need to assess, ensure they have hand washing facilities, they have adequate PPEs and all these things. You need to buy these things and you need to deploy contact tracing teams. You need fuel for the RRT. So it's a resource intensive exercise, and supporting not only the government, but all the health partners that are there in this response is critical. Of course, integration of response. When we have multiple outbreaks at the same time, integrating these together is key so that we can maximize the use of the resources. Of course, continuing to scale up readiness in the countries, neighboring Uganda and Tanzania, and making sure that even the districts that are not affected. In Uganda, cases have been confirmed in only 2 districts. So we need to make sure that all the other districts are ready. If there's any importation, they can detect it quickly and respond. And then lastly, there's the need for the continued investment in R&D, the research and development of the countermeasures. You see the efforts that were done in the Ebola's, the EVD, ensure that we have both rapid diagnostic tests, we have a vaccine, we have therapeutics that can be used for that particular virus. The same needs to be done for the Sudan virus, as well as the Marburg virus and other viral hemorrhagic fevers, so that we reduce the risk of these outbreaks becoming pandemics. And this is, I think, my last message. The other thing I'll talk of is, of course, solidarity. Countries like Uganda and Tanzania are doing a lot for the humanity. Outbreaks will always happen because of the increased interaction at the human environment animal interface. But how do we respond is what is critical, and we can only respond jointly as the global population, instead of segregating or coming up with measures that will only put the countries in precarious situation, than collaborating with them in the spirit of the international health regulation, responding as one global health family. Thank you.
Thank you so much, Patrick, for that very comprehensive and very interesting presentation, which covers a huge amount in a very short time. So thank you very much. We have many questions now. So let's start. It's of course not going to be possible to respond to all the questions. What we will try and do is collect all the questions and see if we can provide some responses later on our website. But for now, there are a number of questions, for example, on the Sudan virus disease. How is it, can you get it from contaminated fruit, feces? And also, how long does it, can it transmit post-recovery? Who would like to answer that? Anais or Patrick? Anais, over to you.
I can start. I already answer in the chat. So if you have a question similar to yours, feel free to read on the chat. But yeah, we will not be able to, although I'm typing very fast, we will need to follow that up. So good question. So I think the transmission with the fruit, I think I replied to that one. It's theoretically possible, although this has not been documented properly for filovirus disease. We know it's the case for Nipah virus, which is a total different disease, but more research is needed. I saw there was a lot of questions about viral persistence in different body fluids. So I will try to give a short but very precise answer. We mostly have data from people who recovered from Ebola virus disease due to Ebola virus. On these people, on the people who recovered, we know the RNA, which doesn't equate infectious virus, can be detected for a long time, especially in semen. And we've seen in Guinea that a transmission had occurred from a male who recovered to his partner through exposure to infected semen 15 months after he recovered. This can happen, but this is rare event. So what you need to know is when an outbreak is, when a patient recovers, it is critical that a sustainable and holistic care program is implemented to address the sequelae the person will have, but also to offer biological testing to people recovered and mitigation measures such as safer sex practices, for instance, or to replace for a small amount of time breast milk, for instance, until all comes back negative. And of course, this program will also support the stigmatization that most survivors will face. Over.
Thanks very much. Patrick, do you want to add anything to that?
No, thank you. I think Anais has covered that adequately, but maybe I can respond to some other question. I see a number of them.
Right, go ahead. Is there any specific question you'd like to respond to, Patrick?
So one of the questions, there's someone asking me to expand on the recommendation to integrate the response across multiple outbreaks. How do you do this? And I think it's one of the things that we, as a region, as I showed, we have countries that have, at one moment, they are responding to 6, 7, 8 different emergencies. And if you are to have, you know, separate teams, and usually in the ministry, all our ministries have very limited HR capacity. So if you have a separate incident manager for each of the emergencies, those are 5 or 6, you know, a person dealing with some.
Yeah, we lost you for a minute, but you're
Okay.
back.
So I was saying that our ministries do not have so many staff. And if you are dealing with 5 or so active emergencies at the same time, having different incident management systems that are responding to this really makes it very, very challenging because you spread the team very thin and they are not able to. So what we are now beginning to work on is then that some of the diseases you can be able to integrate and have one team. And then that looks at, for instance, if you have diarrheal diseases that can be managed by one team. So you have somebody, instead of only doing surveillance for cholera, they do for typhoid, they do for if there's a typhoid outbreak. And for us, even now at the regional office, for instance, we have Marburg and the Sudan virus. We have combined it. We have the same team following Tanzania and the same team following with Uganda so that we are able to maximize the resources that we have. So it's one of the approaches that we can be able to use. Even in the country level, it will really be more resource effective. If you send a team out for contact tracing, instead of them looking at only the contacts for Ebola, what about the contacts for Mpox who could also be in that same area? So they do that follow up. And then, like we always say, you kill 2 birds with 1 stone. So it's really some important aspect that we need to take to improve the management of emergencies in the context of the resource limitations that we have.
Thanks, Patrick. That's great to know how you maximize all our limited resources while managing emergencies. We are actually at the end of this session here, but maybe one more question. There's a question on vaccines. You know, the Ebola vaccine, does it give some sort of protection to the Sudan virus disease? No. There's another question on there's a 2-dose vaccine regime of Marvia and Zabdena. Forgive me because I'm not familiar with these. And one of them is a polyvalent. So does that provide immunity to Sudan virus disease as it's supposed to do for a range of diseases?
This has never been evaluated.
Right.
And two things, this has not been evaluated, so that's first. It is only approved, this vaccine, if you read the EMA regulation for Ebola virus disease. And the big problem with this vaccine is it's 2-dose, so not very useful during outbreak response.
Thank you, Anais. There was also a number of questions on the index case for the Sudan virus disease outbreak. Considering he was a healthcare worker, what was the source of his getting infected?
Okay, I can. So for now, we do not know how he could have been exposed. So he, as a healthcare worker, he was working in multiple, in 3 health facilities almost. And so in this situation, usually we want to see, is it something that happened at the workplace? Was he exposed at home? So it's part of the investigation that is ongoing to try to identify where the exposure could have happened. So the team of field epidemiologists, they are visiting all the facilities that he has been working in, reviewing the medical records to see who were the patients that were at that time when he worked at the facility, what were their presentation. So they will go backwards to try to see if we can. It's usually a very challenging exercise because the person has passed on and you will rely on secondary information. So it may not be very easy to know which are the places that he visited before he became sick. And as you know, the incubation period is 2 days to 21 days. So within that period from 2 days to 21 days, he could have moved to so many places. But that's something that's going to be supported in terms of the investigation. Yeah.
Thank you very much, Patrick. And the final question, I think, considering our time limit, is, the important thing, what can communities do? And what are communities doing? You mentioned a little bit about the anthropologist getting the traditional healer on board as well. Can you expand a little bit more on that, Patrick, and also Anais? Patrick first.
Thank you. Let me start and then Anais will come on board. I think I always say that these outbreaks, they start and they end in the community. So the biggest determinant of interrupting the transmission is the community. And there are a number of things that the community can do. The first is getting the right information, like getting to know how do you acquire the disease, how do you contract the disease. It's very, very important. And we have said that when you come in contact with a sick person, the body fluids, when you participate in the FINRO, FINROLs are one of the biggest amplifiers of transmission. So if somebody has died from the disease and you participate in cleaning and washing the body, then you have a very high chance of catching the virus. So knowing that the virus is transmitted through contact with the infected person, the bodily fluids, their surroundings, the clothes they are putting on and all those, and the dead body is important so that people can be able to take measures to protect themselves. The second one is then if somebody in your family is sick, has symptoms, particularly those people who are in the outbreak area, is to make sure that they report to the health facility, that this person is taken to the health facility where they can be managed. Managing the person at home increases the chance for everybody to be exposed. And Ebola, unfortunately, has that history of almost closing down a family if everybody at the home gets exposed. So early referral of a suspected person or a person who is sick with symptoms to the health facility is very, very important. And then the third issue then is avoiding, these harmful practices, washing of dead body, going to traditional healers, particularly when you have symptoms, self-medication. Some people, they take paracetamol, they buy from the counter, and by the time they reach the health facility, it is too late that they cannot be saved. So those are things that need to be avoided. And I think these are things that has worked before, and the communities are implementing them. And lastly, I would like to emphasize the issue of cooperating with the response measures. So there are contact tracing teams that will follow up. How are you? Check on you every day. It's very, very important not to hide from them, but to cooperate. The second one is the disinfection, decontamination. When there's been a positive case in the home, they need to come and spray and remove the things that they used, because those materials, the bed sheets and what, can still carry the virus and can transmit to other people. So cooperating with them. If you have to be moved to a quarantine so that you protect the rest of the people at home, you cooperate with the response measure. So it's very, very important that the communities get to cooperate with the response measure so that we can be able to interrupt this transmission as fast as possible. I'll hand over to Anais.
Well, I
Over
think
to
for
you,
the sake
Anais.
of time, Patrick, you say it well, and I just want to recall what you said. Everything start and stop in communities, and you can have the best intervention you want. If communities they don't trust you, nothing will happen. Just to clarify one thing, Supriya, I think you were thinking of COVID. We don't have pandemic of Ebola. It's not the same. So we have outbreaks that can be timely controlled. Thank you.
Thank you very much. Thank you very much for that, Anais and Patrick. Both very informative and excellent presentations. And you can see that everyone was interested because end of the hour, we still have 1,000 people online, which is amazing. So I would now like to bring this to a close by thanking all our, first of all, thanking all the presenters, both Patrick and Anais for giving very good presentations for both of them. Unfortunately, Maria couldn't join, but she's also been supportive of this whole matter. I'd like to thank, secondly, all the participants, all of you who joined from all over the world. Please now use this information for the good, for the positive. Work in your communities and whatever you do, share the information and have an impact. That's what we hope to do with EPI-WIN. Finally, my thanks to all my colleagues in EPI-WIN who've been working behind the background. We have Kanika from ECHO, Project ECHO, who's been supporting with the chat, with the presentations and all of that. My colleague Constance from the University of New Mexico, it's too early for her to join. My other colleagues in EPI-WIN, Lester Geroy, who's actually running a workshop right now and couldn't join, Berg Goreglu and Michael, who've been working on this on the webinars. I'd like to thank them all. And most of all, as I said, thank you. As Patrick mentioned, it's a time for solidarity. And on that note, goodbye and see you next week. Next week, we have a webinar on mass gatherings, and I've just shared my screen. Please do join. Thank you.